A day in the life of a neurologist treating headaches. Today was a headache day, and treating headaches can be very difficult, but it can also be fairly straightforward as far as treatment algorithms that we use and things that we do. So I'm just going to talk about, headaches again, but I'm going to talk about it sort of in the framework of a typical day and what I would normally see in a typical day. The first thing that I try to do when I see a patient is determine what type of headache they have. And the vast majority of people we see in a private neurological practice have either tension type headaches, migraine headaches, or mixed headaches. And the vast majority have both migraine and tension headaches. So the medicines that we use are tailored toward the type of headache a patient has. So it's really important to get a correct diagnosis. It's important to get it starting out because you get so many phone calls from patients with headaches, and you want to be able to answer the question, make a medicine change. Someone has a side effect, and you need to look at the chart and see what kind of headache they have. So the most classic headache was described like in 400 BC. It was a king, and he saw what we could call fortification spectra, but it was like the little lights on top of a medieval castle wall, the torches on a medieval castle wall. He saw these little squiggly lines, and he described it. And so this was called fortification spectra. He would get this fortification spectra, and then the headache would come, and he'd get a severe headache, throbbing, pounding, nausea, vomiting, photophobia. He was sick as a dog. And they tried all kinds of things, and leeches, and they finally started cutting him, and they actually bled him to death. They actually felt better by being cut. And so he died from the treatment, and that was the first description of a classic migraine. What we call migraine with R, what they've called for years classic migraine. So that's rare. I mean, this week I haven't seen one person with a classic migraine or a migraine with R. Most of the ones I've seen have been migraine without R. It's the very same symptoms, but no R, no warning. So severe, throbbing, pounding headache, nausea, vomiting, photophobia, which is aversion to light, phonophobia, aversion to sound, and just unbearable. A rare form of headache I see, and I haven't seen one of these this year, is a cluster headache. Same headache, 4 o'clock every day for 2 weeks. Then they don't have them for 2 years. Terrible migraine, but it's in clusters or cycles. They're usually more retroorbital. Eye will water. That's a telltale sign. Sometimes the eye will even turn red, and the nose will stop up or run. Facial redness, and just a terrible cluster. And then an ice pick headache. I saw 2 people this week with an ice pick headache. Felt like somebody stabbing their head with an ice pick. I love these kind of headaches because oftentimes you put them on indomethacin. It's an old anti-inflammatory. One of the first ones we had after naproxen. So 40 years ago, we used to use it a lot. Made everybody sick at their stomach after time, so we don't use as much, but it'll stop these kind of headaches in 2 or 3 days. So what am I doing when I'm trying to find out about people's headaches? Well, I ask when they began, and are they focal or generalized? Migraine headaches are oftentimes they're focal, like in the temple. Tension headaches are generalized, like a vice pressing on your head. How frequent do they have the headaches? And every patient I saw this week, if they're more than 3 days a month ruined by a headache, I want to put them on a preventive drug. So I wonder how frequent. Do they have nausea and vomiting? That's rare in tension headaches. Very classic for migraine. Terrible headache, throwing up your guts, and that's a migraine. And then does sound affect them? Does light affect them? Very uncommon with tension headaches. And you always want to know what the treatment history is. I saw a young girl this week. She was 19, just gorgeous young girl. She has about 4 headaches a month, but they're terrible. Throbbing, pounding headaches, nausea, vomiting, just lays in bed in a fetal position. Classic candidate for Inderal. Inderal is a beta blocker, safe in pregnancy, safe in breast milk. Young people tolerate it very well. So I put her on Inderal. I suspect she'll do very well. And then we talked about something to take for the headache. And in her case, I put her on Maxalt, just a half-strength Maxalt, because Inderal doubles the strength of Maxalt, which is one of the triptans. The negatives about the Inderal for her is that it takes 3 to 6 months to get the dose right so it worked, but she could take it forever, rest of her life. So I put her on Inderal, just told her to be very, very patient. I saw a black guy today, bald, hypertensive, super guy, man. He was such a super guy. and he's having these terrible migraines, and I put him on verapamil because he has hypertension. And Inderol, like I put the young lady on, can make men, particularly black men, impotent and affect their sexual functions. It's been a terrible choice, so I put him on verapamil. I might try Atacand next, another blood pressure medicine. I saw a lady this week that was having mixed headaches, but mainly tension headaches, but she had a significant amount of depression and anxiety. And if you remember, we talked about this before, you know, with headaches, you see a constriction of blood vessel followed by vasodilatation. We use antihypertensives for this first pathway, then a release of chemicals, and then a tsunami of electricity across the brain. Release of chemicals, antidepressants, tsunami, anticonvulsants. And then we're focusing on the fourth trigeminal vascular mechanism, the CGRP peptide release that is high in pain, high in the brain and neck. So it's a fourth mechanism that we use. But this lady was depressed but anxious. And she was about 30 pounds overweight. Elavil and Pamela wouldn't be good for her because she gained weight. Effexor or Cymbalta would be great choices. Try to treat and kill two birds, in her case, 3 birds with one stone: depression, her anxiety, and her headache. So I put her on Effexor, very low dose. You know, one mistake we make with these drugs, and I hear this even in the comments when people write to me, is their doctor just started them on too high dose. They just start on a baby dose, because a lady like this, there's only a few things that I would want to give her if she was my baby sister. Start her on, you know, Effexor 37.5 milligrams a day, and I'd probably try Cymbalta next. Same thing with it, just low doses, 30 milligrams a day. Both are a little bit upper, so I usually recommend taking them in the morning. Then we just saw this lady. She's 80 years old with headaches, doesn't sleep real well, tension headaches. I put her on Pamela or nortriptyline, baby dose, 10 milligrams QHS. It increases serotonin and norepinephrine. Wouldn't have had a problem with putting her on amitriptyline or Elavil. You know, I only use Elavil really in elderly people. Pamela and Elavil both can cause weight gain in 80-year-old ladies. Thin, you know, it doesn't hurt, you know. I wouldn't put up that beautiful young 19-year-old girl on Elavil or Pamela because they probably gain weight over time. You know, we sometimes, you know, use Wellbutrin in a lady like this lady with anxiety and depression. I'm not a big Wellbutrin lover, but we can use it. And then I saw multiple women this week, 40s, 30, 40 pounds overweight, tension type headaches. And I went through the third mechanism and put them on Topamax. I'm surprised it's not been released as a diet pill, because it definitely, you know, can make you lose weight. Depakote's a great choice. Keppra is a good choice. I saw a lady today who was having headaches, and we talked about the different medicines, but she has significant psychological and psychiatric problems. And we talked about Keppra. No way I would give her Keppra. That's the one idiosyncratic reaction with Keppra is psychological problems. And then I saw another one of these really nice black guys earlier in the week, and he had migraines, and I put him on Depakote. Once again, he's bald. Depakote can cause some bald. He wouldn't put a woman on Depakote for a bunch of reasons, but one of them is to make you lose your hair, alopecia. And so I put another man on Depakote. So many times, you know, you'll see these patients, and we saw one like this today that came in. She's doing a lot better on Inderol, and we talked to her, and still having some tension headaches, still having more headaches she wants. She has some anxiety, so we added Effexor to it, Inderol, Effexor. So you try to blend the 4 pathways together. Sometimes low doses of 2 things work. Today was another busy headache day. Saw a lady she's been on Elavil for 20 years. She'd taken Inderol when she was younger, it didn't work. She took Topamax, didn't work. Keppra made her crazy. Perfect candidate for the new CGRP, Amiovig. Man, these things have been life-changing for a neurology practice. Once a month Amiovig, just a shot once a month. And these things just work great. Got to give them 3 months to work. CGRP is a very small protein. It's very prevalent in the sensory nerves that supply the neck and head, and released in pain, released in migraine. It's involved in pain perception, greatly increased during migraine, and these CGRP inhibitors block CGRP. There are 4 monoclonal antibodies. I prefer Amiovig, and then Ajovy, then Emgality, any one of those 3. Vyepti, it just put maybe less than 5 people on Vyepti, and you know, Had a lady had her first dose that came in today, just so nauseated and so sick. I've got to get a better feel for Vyepti. And we generally don't get to it. You know, generally Amivig or Ajovy or Emgality work. Another drug we've started using, and we put a new patient on it today, been on several different things, is the prophylactic Qulipta. It's not a monoclonal antibody, but it blocks the CGRP in intracranially in the brain. I think this is one that I'm probably really going to like. We really just started using it a lot toward the end of last year because insurance just wasn't paying for it. But it's, you know, once a day, and it's a preventive. So it'd be sort of like some of the old drugs we use, like the Inderols and Topamaxes and Pameloids. So once a day drug, prophylactic, preventive. We put a lady on today. And then Nurtec is a Gepant that came out. It was the first one that came out, and you use it just for pain. And now you can use it for prevention as well. Over 50% reduction in severe migraine days with Nurtec. Once again, I found that to be really helpful to combine with something else. But I love Nurtec. You know, Nurtec, you know, Emgality, Amivig, Ajovy, they're probably my top 4 in these Gepants and monoclonal antibodies, the CGRP inhibitors. Now, the old drugs still work great. And like that young girl today, I put on Maxalt. The gentleman that was a black guy that I put on Verapamil, I gave him Imitrex. It seems like, and this is my bias, it seems like triptans, particularly Imitrex, really work in black men and women, and they work great. I always ask about cardiovascular risk factors with the triptans because there's some risks to that. But I mean, Maxalt is by far my favorite. I start Imitrex in black Americans. Relpax is not as accessible, or Zomec anymore. I used to love Emerge and Frova. You know, the insurance companies don't support their use anymore, but you know, when someone has like a status migraine, I'd love to give them Frova, you know, 1 twice a day for 4 days, and Emerge 1 twice a day. So they're great, you know, triptans. Any one of these work. Ergotamines are just sort of hard to get. We use tons of Cavergot, which is not on the market, but you've got a nasal spray now, and still love DHE 45 injections. You know, don't have to use it a lot, but people that just, only thing that works, you know, we give it to them. So not today, but today's like Wednesday, Monday, I gave somebody Zavbreath, the new nasal formulation of Nurtec. It's going to be interesting. Migraine drugs sometimes are not absorbed as well and people are nauseated. It's going to be interesting to see how well this works. I just haven't had a lot of people that really loved it. You know, it's sort of interesting. In the South, people hate putting things up their nose. You know, up in the North, people are so used to being cold all the time, they're used to nasal sprays. But it's definitely worth a try. And it's something that, you know, we definitely want to try. And so we'll wait and see what that person said. This week, not today, but this week, I ordered Botox for at least 2 people. If you have more than 15 headaches a month, these patients, I had treated them with everything. They'd failed every class of drugs: beta blockers, calcium channel blockers, antidepressants, anticonvulsants, CGRP inhibitors, monoclonal antibodies, Gepants. They'd failed everything. They have more than 15 headaches a month. Botox, you know, it's great. You know, I did Botox for 30 years for dystonia. It was like hemifacial spasm, dystonia after stroke, blepharospasm. And when it came out for headaches, I wasn't a big believer in it, but man, I am now. There'll be some years to go by, and there's not a single patient it didn't work on. 31 injection sites around the face, temporal lobe, back of the head, trapezius. I mean, it's just amazing. So try Botox, and 155 unit injection, 31 injection sites. So make sure you're getting from somebody experienced. That's sort of my week for headaches. So do I order MRIs on all these patients? Yeah, I do. Everyone. You know, I've said this many times on these videos. You can tell a person they have a brain tumor. They don't believe you until you get an MRI. So particularly if they have any red flags, you know, any systemic symptoms like fever, weight loss, if they have HIV or cancer, automatic MRI of the brain, any confusion or personality changes, any weakness or numbness on one side of the body, acute thunderclap headaches, worst of their life, MRI and MRA. Any patient over age 50 who onset headaches, get MRI. Or if you have a prior headache history and it's changed, the character's changed. So pretty busy week, seeing a lot of tension headaches in migraine patients, but just hearing this, you can see there's so many choices. Try something, it doesn't work, try something else. And caution all providers out there, and even patients, when you talk to your doctor, make sure they start you on a very low dose. There's only probably a few things that'll work well for you. Don't start on an adult dose. Start and build up. We're not treating infection, so take your time. That's a day and week in the life of a neurologist treating headaches. This is Dr. Caldwell, the Brain Doctor. Like, comment, subscribe. More later.